Well, thank you. Well, good morning. Everyone hear me okay? Okay. Uh, I was invited here to talk to you a little bit about using the IQ 532 laser, and I'm a comprehensive ophthalmologist, and I live in a small rural town, and this laser I purchased last Academy meeting, and I just want to talk to you a little bit about what you can use it for from the anterior to the posterior segment as a comprehensive ophthalmologist. Financial disclosures, I did receive a nice gift basket from Iridex for lecturing today, so I just wanted to let you know that. Some of the goals of the lecture we're going to talk about, we're going to describe the MicroPulse technology. We're also going to discuss how to use it for the anterior segment as well as the posterior segment. We're also going to talk about the advantage of the IQ 532 laser for the comprehensive ophthalmologist. Now the MicroPulse IQ 532 gives a fine control of the photothermal effects. It's using tissue-sparing technology and generating a sublethal elevation in the temperatures of the tissue, so therefore we don't see any destruction of tissue with this laser technology. Now there's multiple uses that we can use for this IQ 532 laser. In the MicroPulse mode is what we're going to be mostly talking about today, and that's using it for the anterior segment and doing laser trabeculoplasty, or what I'll refer to as MLT. And we can also use it for the posterior segment for treatment of the retina, whether you have macular edema due to diabetic macular edema, central serous retinopathy, branch retinal vein occlusions, and central retinal vein occlusions, along with even radiation retinopathy. Now, what is the mechanism behind the MicroPulse technology? Well, it uses a continuous wave laser that's basically chopped into short segments. And these short pulses will minimize the tissue laser-induced heat that can spread to the adjacent tissue. So therefore, you can chop it up. It's kind of like if you're a phaco surgeon or you know about phaco technology. When you get into the duty cycles of certain machines, like the White Star system was designed to not cause a phaco burn. If you held on to that phaco tip and you put it into a duty cycle, the heat wouldn't generate up enough. But as soon as you take it off the duty cycle and you put on continuous power, you'd burn your hand in about a second or two. So the idea behind this is that you're going to try to generate elevation in the tissue temperature but not cause any thermal destruction. So if you see the picture on the top, there is a picture of a continuous wave laser, and what you can see is that as the laser technology, as the temperature, the laser turns on, and as it goes across, we can see the thermal energy is delivered to the tissues, and what you'll see is a rise in the temperature of the tissue as the tissue is being treated. Once the laser technology goes off, then it cools down. As we go into MicroPulse, what we're doing is now taking that laser and sectioning it into multiple areas of treatment. So with a MLT, we'll typically use a 15% duty cycle. With a retinal grid, we'll use a 5% duty cycle. And so what we're doing is delivering the laser over short segments, so we never really get to destruction of the tissue because it allows time for that tissue to be cooled off. So it's kind of like when we learned in medicine is to do no harm, and this is what's nice about this laser is we're not seeing any thermal destruction of tissue. This is a EM microscope of a 533 yellow laser that was done by Nucker. And what you see here is he was using a 50 micron spot size with 1,000 milliwatt power and 100 millisecond duration. So this is basically your classic ALT. And what you can see is you can see thermal energy that's been applied to the trabecular meshwork, and you can see actual destruction of tissue with that. Now, if we compare that to the MicroPulse model of the same thing, if we use a 300 millisecond and a 300 micron spot size and 1,000 milliwatts of power, you can look at the MicroPulse treated trabecular meshwork versus that of the control, and you see no thermal energy destruction of the tissue. So we're delivering that energy but not causing any destruction of the trabecular meshwork. Now with laser trabeculoplasty, the traditional laser trabeculoplasty, we use that to basically increase the outflow facility of the trabecular meshwork. It's used to treat patients with elevated intraocular pressure. It's pretty effective in those patients with primary open-angle glaucoma, with pigmentary glaucoma, and also pseudoexfoliation glaucoma. Typically, we don't want to treat patients with neovascular glaucoma or problems with uveitic glaucoma, so we'd want to avoid the laser in those type of patients. If we look at the classic ALT and compare that to the SLT laser, With argon laser trabeculoplasty, we can see shrinkage of the trabecular meshwork and adjacent stretching of the tissue, which allows the fluid to go through the trabecular meshwork better. Typically, you can't repeat an ALT, and you use a small spot size, a 50 micron spot size. When we look at selective laser trabeculoplasty, it targets the intracellular melanin and activates the macrophages. It uses a larger spot size. It is repeatable. However, the machine itself is relatively expensive, and it does have limited use in the fact that you can only use it for SLT. Now, when we look at MLT, which is using the MicroPulse technology, it's very similar to SLT in the sense that there's no thermal damage made. We think it does target the intracellular melanin and activate the macrophages to stimulate outflow of fluid within the trabecular meshwork. We do know it is repeatable. I have repeated it so far, and I've had results with that. And the laser itself is less expensive, but the advantage to this laser, it gives you multiple uses too. So you have the ability to use it as a continuous wavelength laser, you have the ability to use it as a micropulse laser, and we'll also talk about what you can use it for in the retina too. So pretty exciting technology. When I first got the laser, we kind of looked at what settings should we use, how do we do this, what's the power to be used, because it's really new technology and no one really knew exactly what to do. So what we did is we first looked at 13 eyes that were newly diagnosed with open angle glaucoma. And these patients elected to undergo MLT procedure. The mean IOP was 26 millimeters of mercury, and it ranged anywhere between 21 and 38 millimeters of mercury. Now, these patients have had no previous treatment, and 5 had an ALT in the fellow eye. So with the initial treatment, we used the IQ532 laser, and we used the pre-op drop of bromidine, 0.15%, and prednisolone acetate. We started using just 1 drop of Pred Forte preoperatively. It seemed to help with the photophobia some people got a little bit after the laser treatment. And we used the rich 4 mirror lens. So the initial treatment parameters, we used a 300 micron spot size with a power of 300 milliwatts and a duration of 300 milliseconds, a duty cycle of 15%, and we treated 360 degrees. So when we looked at 4 months post-treatment, we saw that the preoperative average IOP was 26 millimeters of mercury, and our postoperative treatment was 21 millimeters of mercury, or approximately 18% reduction in the IOP with one treatment, 360 degrees. There was one patient, if you look at patient number 11 there, the pressure actually did go up, went up 1 point or approximately 5%. I subsequently treated that patient with continuous wavelength ALT, and it never changed her pressure. So whether she was going to be a non-responder, whether you did ALT or MicroPulse, so from that situation, we don't know. We then looked at, do we increase the power? Do we go up to, say, 700 milliwatts of power using a spot size of 300 microns, exposure of 300 milliseconds, and a duty cycle of 15%, and we treated 360 degrees again. We took a look at 1 month post-treatment with the 700 milliwatts of power, and we see that the mean pressure was 23, dropped to 19, or about an 18% reduction. So very similar to the 300 milliwatts of power. The only difference is that we had no non-responders, so everyone seemed to have responded to this treatment. There is also some people, like patients 3, 4, 8, 11, and 12, had previous ALT already. So now we're trying to do it in patients who have had previous laser, and you can see even though they've had previous ALT, they still responded to the MLT. So this was nice because before we couldn't really repeat the ALT anymore, but now we were able to use the MicroPulse on patients who have had previous ALT, and we still saw a response. And patients 3 and 4 were already on aqueous suppressors too, so even though they're on drops and they were probably brought down from a higher pressure on the medications, they still respond pretty well too to MLT. So when you looked at the no previous laser eyes and then the previous laser eyes, we saw a mean pressure of 24 going down to 20 if they haven't had previous laser, or about an 18% reduction. On those who have had previous laser, about 21.5 millimeters of mercury down to 18, or a 17% reduction. The next thing we did is, let's look at 1,000 milliwatts of power. What happens when we increase the power to 1,000 milliwatts using the same spot size of 300 microns and the same exposure duration of 300 milliseconds? and a duty cycle of 15%, treating 360 degrees again. Well, we don't know what the outcomes are yet, but what we've seen so far is about a 19 to 22% reduction in the pressure. So we are seeing a little bit better reduction possibly with 1,000 milliwatts. I haven't seen all those patients back yet, so I'm not sure what we're going to be at in 3 months or 6 months. What I can tell you though is I had one patient, if you went back on the slides, a patient who had a pressure of 25 initially, was treated with 700 milliwatts of power. She went from 25 down to 22, and then I treated her with the 1,000 milliwatts, and she went from the 22 down to 17. So from that standpoint, we see it's repeatable and also maybe get a little bit more effect with the higher power. So the questions we had were, what's the best power to use? Is it 300, 700, or 1,000? I think overall, probably starting with around 700. Some people use 600 or so, but I think the 700 power to start with is probably a good number. I may change my mind once I see more results back of the 1,000, and I may increase it a little bit. Or the question is, do we prime the pump using 700 and then hit them with 1,000 afterwards, and we see even more effect? I don't know. So this is going to be all kind of interesting things that we're going to learn about this laser down the road. Some of the long-term effect with ALT, we know about 80% of those people will have some effect at 2 years and about 50% in 5 years. But with MLT, we don't know. We haven't seen it long enough. We've only been using it for about a year now, and we hope to see some effects lasting a lot longer. But the nice thing about this procedure, though, it is repeatable. So MLT is an option. The advantage of the MLT is it's that we can use it in those patients who have lost effect over time, who have been on previous medications or have had previous laser and they're failing therapy. Also, people that have had previous ALT, like we said before, it still works. The benefits to the patient, the doctor, is that it does save money. You don't have to worry about medications. You don't have to worry about the compliance of these patients. As you know, a lot of patients have difficulty remembering to use their medications, and if they're on multiple medications, then you have to worry about corneal toxicity and all those effects too. So over time, it's a nice advantage to those patients, and also as you as a physician knowing that you've treated these people and hopefully kept their pressure down. And the other advantage is that it does have multiple applications from the anterior to the posterior segment, and that's where I'm going to kind of transition into now and talking about the use of the MicroPulse laser in the posterior segment. So once again, this is our model of the continuous wavelength laser. As you turn the laser on, over time the heat's going to generate, and the heat's going to generate into the tissue, and that's what's going to cause some thermal destruction of tissue. The advantage to this laser is in the continuous wavelength mode. You can use it for your traditional macular edema if you want to do a traditional grid or a focal laser on them. It's good for patients with proliferative retinopathy if you want to do a PRP, and people with neovascular glaucoma who needs to be treated. It's great for treating retinal tears, and also if you had a patient who didn't want anti-VEGF therapy and had a choroidal neovascular membrane and need to be treated, you can do it also with thermal laser too. So in the posterior segment, we're talking about MicroPulse mode for macular edema, and you can use it for a wide variety of things, from diabetes to branch retinal vein occlusions, central retinal vein occlusions, radiation retinopathy, and also central serous retinopathy. So with the posterior segment, with the MicroPulse mode, what I typically do is we'll create a test spot. And I'll start off with a 100 micron spot size, use 100 milliseconds and 100 milliwatts of power, just like you would with a traditional focal grid treatment. And then what I'll do is titrate up the power from 10 to 50 milliwatts until I see a white burn. Once I have a white burn, then we'll switch it over into the MicroPulse mode at a 5% duty cycle. We maintain the spot size, but I'll double the exposure time and also double the power. So this would be a video about how the treatment would take place and look. And I apologize, I was by myself that day. Usually the residents are doing all these treatments for me, but you can see how the MicroPulse mode, you'll just treat in a kind of a paintbrush technique and just kind of go across and apply that laser energy in a grid fashion. What I'll do is work my way horizontally and then work my way vertically, going over the area multiple times. And this was a case of the patient with diabetic macular edema. You can see they've had some previous laser work too. Once again, I apologize for not the clearest of videos, but I just tried to throw one in there to show you what it looks like. So I'll just go through a couple of cases. This was a 28-year-old who had type 1 diabetes. They've had some previous focal grid laser treatments back in February of 06 and also July of 08. And the OCT, you can see, demonstrates the macular edema present. So this was using the MicroPulse treatment. This was back in December of 2011, when at that time I wasn't really quite sure what the power setting should be in it. So we started off using 100 micron spot size. I doubled the duration to 200 milliseconds, and at that time I was using only 70% of the power. So instead of doubling the power, I only used 70%. And I'll show you what happened. Basically, nothing. not much at all. So we looked at this patient and said, well, didn't really do a whole lot. But in March, I learned better. I said, oh, I got double the power now. So here we are in March, and this is afterwards in April, after 1 month of treatment. I'll show you a transition here in a second, but you can see how much the edema resolved using the higher settings. So here they were back in previous treatment. Here's after the MicroPulse at 70% power. We didn't see much effect, but then here we are a month after with the higher power settings, and we can see a lot of the resolution of the edema at that point. Here's another patient who had type 2 diabetes, a 75-year-old who had focal grid treatment back in February of 08, had some Kenalog treatment, and also a grid with a combination Kenalog. And you can see the macular edema there. Here, this case was in December, so at that time I was using 70% power, but the interesting thing is I got effect with even at 70% of the power instead of doubling the power. I don't recommend doing that anymore. I still recommend doubling the power and using the higher power settings, but it was interesting to see that we even had an effect with that too, so a pretty significant one too. And this is a case of a 68-year-old with type 2 diabetes who's had previous Lucentis treatment and also Avastin, and she just said, you know, I don't want any more injections. So I said, okay, well, we have this other technology called MicroPulse technology. We can try to treat that and see how you do. So in this case, we used 536 shots of 100 microns, 200 milliseconds, and 300 milliwatts of power because our whitening took place at 150. And you can see some effects. It's not perfect yet, but definitely a lot of resolution of her macular edema, where before she was still having this chronic edema that she couldn't get rid of, and she just didn't want any more anti-VEGF treatment. So the MicroPulse mode did help lower the amount of edema essentially and reduce some of her metamorphopsia that she has. This is a 76-year-old who had previous grid treatment back in September of 2007 with the branch retinal vein occlusion. Also had some Kenalog. I think they may have had Ozurdex too. I'm not sure. I can't remember on this one. But this was using the lower power setting once again, because this is back in November of last year. We used 200 microns, 200 milliseconds, 150 milliwatts, which was about 70% power at that time. And we did see some resolution of the macular edema, not fully, but we did see some effect even with the lower power. So once again, we learned from that, and we now use the higher power setting, and you can see the difference once you use higher power. It was able to resolve the macular edema from his branch retinal vein occlusion with that higher setting. So it was pretty impressive with that. And here's a transition of the different OCTs. You can see with the lower power setting, we did have some resolution, but with the higher power setting, comparing the pre-treatment OCT with the post-treatment OCT, we can see marked improvement of that macular edema, so pretty impressive. I think this is the most interesting case, actually. This is a 41-year-old who came in with a branch retinal vein occlusion, no previous treatment. I discussed the use of MicroPulse treatment for her. And so MicroPulse treatment was carried out in February of 2012, 377 shots, 100 microns, 200 milliseconds, and 400 milliwatts. Now, if you look at something, look at the date. This is February 22nd, and this is February 29th. This is less than a week out. Look at the edema, how quickly that went away. it was unbelievable. I would have never gotten an OCT or did this a week later. I usually tell the patients, come back in a few months and we'll take a look at you. But she came in for some other reason, said, hey doc, my vision's so much better. I'm like, yeah, right. So I said, well, come on back, let's just do an OCT and take a look. And sure enough, it was so much better. And to me, that's just an amazing, amazing case. That in 6 days, you could see that effect. Now, this is a patient with a CRVO who's had previous PRP for neovascular glaucoma. She had chronic macular edema and declined any anti-VEGF treatment at that point. So even with the chronic macular edema from CRVOs, I typically don't treat CRVO macular edema with a traditional grid laser because it really doesn't work well. But I said, well, let's try MicroPulse. Let's see what happens with it. And so she had MicroPulse treatment done on March the 1st. She had 313 shots, 100 microns, 200 milliseconds, and 200 milliwatts. And you can see that even 6 months later, a lot of the edema is resolved out. So from that standpoint, even with chronic macular edema, you might be able to get some effect using the MicroPulse technique. This next case is a patient who had radiation retinopathy. It happens to be my golf partner, and he was a 71-year-old retired Vietnam veteran, and he was over there and developed ocular lymphoma later in life, and he had a history of previous radiation treatment, and so he developed some macular edema from his radiation treatment. And I discussed with him some options for treatment of it, and so in this case we used the MicroPulse technique. Once again, 278 shots, 100 microns, 200 milliseconds for 200 milliwatts, and we are able to even see some resolution with patients with radiation retinopathy using the MicroPulse laser. So in conclusion, we basically looked at using the MicroPulse technology from treatment of the anterior segment, whether you're doing MLT or MicroPulse laser trabeculoplasty, to the posterior segment, looking at for treatment of macular edema with the MicroPulse. The IQ532 laser is a great laser because it has a great versatility. It's an excellent choice for those people who are comprehensive ophthalmologists who do anterior segment work as well as posterior segment work. It gives you the benefit of that continuous wave laser, so if you want to do a traditional ALT or peripheral iridotomy, a focal grid treatment, whether you have to do a PRP or treating retinal tears or choroidal neovascularization, it gives you that benefit. Or you can switch it over to the MicroPulse mode and use it for treatment for MLTs and grids. And future technology, we just don't know. There's some options maybe in the future of using this laser for other things, and hopefully over time we'll learn a little bit more about it. I do want to thank a couple of my residents who helped put this together, and they did a lot of the actual laser work too and stuff, so from that standpoint I want to thank Dr. Warner and Dr. Benjamin for that. And for any state fans out there, go State. Now, this is what my wife gave me this for my birthday, and so it's on the back deck. I can just turn it on and have some fun. So, but thank you.